Right. Welcome everyone to Weight Inclusivity and Rejection of Diet Culture. My name is Sabrina. I'm the program director at the Eating Disorder Foundation, and I'm so glad that each of you are here this evening. This workshop is brought in collaboration with the Eating Disorder Foundation and the Gaudiani Clinic. A little bit about those organizations. The Eating Disorder Foundation was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based nonprofit that is now happy to be serving people on a national and international level. The Gaudiani Clinic is a health at every size informed and expert medical provider for eating disorders. They embrace treating people of all shapes, sizes, ages, and genders. The Gaudiani Clinic is licensed to practice in over 35 states via telemedicine and offers international professional consultation as well as education. The workshop tonight is being recorded and will be posted as soon as possible. I will send everyone a notification whenever it gets posted. We are using the chat feature tonight. It will be kept confidential, so any questions or comments will come directly to me. And then at the end of the presentation, we'll save some time for Q&A. Our presenter has agreed to save some time for Q&A. Please do note that we'll likely not be able to get through everything, as this is a very well-attended event. So we'll do our best to get through some of those. Quickly, I'd like to thank everyone who is able to contribute a donation for this evening's workshop. This is how EDF is able to provide our services, and we're very appreciative of that. If you'd like to make a donation in a moment, I'm going to put some quick links to the Eating Disorder Foundation's page and the Gaudiani website so that you can continue to have these resources in the future and find more information. And now it's an honor for me to present our speaker this evening. Dr. Jennifer Gaudiani is the founder and medical director of the Gaudiani Clinic. Jennifer is board certified in internal medicine and a certified eating disorder specialist supervisor, as well as a fellow in the Academy for Eating Disorders. Jennifer completed her undergraduate degree at Harvard, her medical degree at Boston University School of Medicine, and her internal medicine and chief residency at Yale. Prior to founding the clinic, Dr. Gaudiani served as the medical director at the Acute Center for Eating Disorders, which is a Denver-based inpatient medical clinic. Jennifer has lectured nationally and internationally and is widely published in scientific literature, as well as being a former member of the editorial board for the International Journal of Eating Disorders and the Academy for Eating Disorders Medical Care Standards Committee. And lastly, in 2019, Jennifer published her first book, Sick Enough, a guide to the medical complications of eating disorders. And this book is available on Amazon. And if you happen to be in Denver, we also have several copies at the Eating Disorder Foundation and would be happy to lend any copies out for whoever is interested. And Jennifer, I'm going to pass along to you now, and I'll post some links in the chat so that people can continue to have this information. Thank you so much.
Thank you so much, Sabrina. My warmest gratitude and appreciation for the brilliant folks at Eating Disorder Foundation. You do such good work. Welcome, everybody. I am really delighted to be speaking with you tonight on one of the subjects I am most passionate about, and that's weight inclusivity and rejection of diet culture. And perhaps in the spirit of what we're talking about, I would like to share with you a moment of personal story, which is that I just came from family dinner where I enjoyed a lovely tall glass of chocolate milk, a lovely heaping bowl of homemade pasta with brown butter and crispy sage. My 13-year-old made the homemade pasta while I was working today, and steamed broccoli done the only way that I think is appropriate, where you upend the olive oil bottle afterwards and then put some delicious lemon on it, salt and pepper. So good. So I'm coming into this talk fueled and rested and excited to speak with you. I hope that by the end of this talk, you will better understand that focusing on weight as a primary outcome does more harm than good. that classic health outcomes associated with weight loss are achieved or surpassed by improving physical activity and cardiorespiratory fitness independent of BMI, and that a weight-inclusive approach should be offered to everyone. I'd like to set the tone. This is one of my favorite quotations. We must encourage practitioners to locate the problem of fat shame in society as opposed to the individual person's body, and provide individuals with tools to identify and resist fat stigma and oppression, rather than provide them with tools to reshape their bodies. Let's start out talking about the biological, psychological, and social justice-oriented perspectives on why we have to stop as a medical field, as a society, focusing on weight as a primary outcome. Most of us were taught that thinner people are healthier than fatter people, that weight is a product of individual choice and self-restraint, and it's all about calories in, calories out. And that if people could just stop overdoing it, they'd be thinner, healthier, and happier. Needless to say, I'm going to work to debunk all of this. I want to talk about thin privilege. I love this quotation. Thin privilege is never having your body shape used as a shorthand in books, comic books, and movies for gluttony, greed, or villainy. Not to mention, when we talk about thin privilege, we have to acknowledge that thinner bodies move through the world much more easily. Restaurant, airplane seats, clothing availability, job promotion, finding a partner, avoiding stigma and undertreatment or mistreatment in the doctor's office, protection from microaggressions. The power of thinness, as our society defines it, is immense. And I want to recognize that among my other points of privilege, I sit with thin privilege as well. And we can't underestimate the power of thin privilege in causing and sustaining eating disorders. As many have pointed out before me, children are bombarded from an early age with the idea that the villains are round, they're heavy, and the glorious, innocent, deserving romantic interests all look remarkably the same. And they have no body diversity whatsoever. So in our society, we are never without reminders of what body type is safe, desirable, appropriate, and even moral. And what's the result of this? Well, we're going to talk about a bunch, but one of them is that by 2027, the global weight loss and weight management market is expected to reach almost $300 billion. I don't know if you think that might motivate people to keep focusing on thinness and thin privilege, but I think so. All right, let's talk about the biology of deprivation. Let's get right into the science. For any of my patients and their families on this, you have heard this. This is what I go over with everybody. Our brains evolved to protect us from death by starvation. When we were evolving, our ancestors developed exquisite capacities to recognize inadequate nutrition in our environment and change how our bodies work in order to protect us whenever possible from weight loss and whenever possible from death by malnutrition. And of course, this topic relates not just to eating disorders, but anyone who's experienced malnutrition. And I call this part of the brain as it evolved, the cave person brain. Now, malnutrition does not refer to a thin body size. It means insufficient energy intake for whatever reason compared with what a body needs. So the cave person brain says, I will slow your metabolism to save your life when it doesn't get enough calories for a day, for a week, certainly for anything longer than that. And when I talk about metabolism, generally I mean it alters the way your body works in order to use less energy. So How does it do this? Well, it does it in myriad ways. It is the very source of the work that I do with patients. But among the ways are that it gives us cooler body temperatures, including hands and feet. It may slow our heart rate so we don't waste a calorie on a beat of the heart. It slows our digestion because wriggling intestines are not considered life-saving. Eventually, sex hormones may revert to pre-pubertal levels, which can contribute to fragile bones and injuries. And then our brain changes too. A starved mammal is not playful and creative and spontaneous. It is focused, serious, and intent. And a lot of people would say that when they're not nourishing well enough, those become more of the traits, more anxious, more focused, a little paranoid. That's the mammal in us, sensing that we're not safe because we're not nourishing ourselves well enough. So we don't have space to enjoy some of the more joyful elements of our personalities. Then in addition, we are programmed biologically to develop a drive for food. Now, can eating disorders overwhelm that? Yes, to a certain extent. But almost all of us, when we're not getting in enough nutrition, begin thinking more about the thing that's not available. Our weight is almost always preserved, and sometimes in the beginning of restriction, weight can fall. And in some cases, in those with anorexia nervosa, weight can become quite low. However, the vast majority of people who restrict their calories do not significantly lose weight or become visibly emaciated. And then your body is so smart. It's such a miracle. It says, oh, when you're through this period of famine, I will not only make sure that you get back up to the weight that your genetics say we want to be at before you started the famine, but I'm going to make sure you gain some more because it seems we might be in a dangerous environment. So I want to make sure you have more weight so you even better survive the next period of inadequate nutrition. I should say that each individual person may have one or two of these medical complications. Some have none. It just depends on how your unique body responds. What's really important is that weight may or may not change with eating disorder behaviors, and that just depends on your genetics. When I talk about sensitive genetics and survivor genetics, it's a way of trying to validate each person's lived experience with how their unique body manages when they're not nourishing enough. I have patients who, within months of beginning eating disorder behaviors, their bodies fall apart. They aren't functioning, they feel terrible, they have no energy. And usually the mean eating disorder voice says, I'm so ashamed of myself. I can't believe that I couldn't go longer in this eating disorder, or that my body couldn't come to resemble one that I saw on social media. And I have other patients who have lived in their disorder for so long. And yet, even though they still have complications, they're functioning at a remarkably high level. And those patients too may say to themselves, I am so ashamed. Clearly, I'm not doing this well enough because there's not enough wrong with my body. So once again, I'm not sick enough. And you just start to get the sense that eating disorders are never satisfied. There's never a circumstance in which eating disorders validate, provide compassion, and give care. You can't win. As long as medical providers and clinicians don't challenge our internalized size biases, where we are taught to believe thinner is better and healthier, we, I myself included, will continue to harm our patients by imposing diet culture upon them. Unless we advocate for an inclusive, body-neutral philosophy, we ourselves are causing and maintaining eating disorders, weight cycling, and probably the rising average BMI of the country. In the big picture, as long as we are contributing to thin privilege in our work and lives by upholding a hierarchy of bodies deemed worthy, given our power as clinicians, we are the problem. We can do better. I invite you all to fight the instinct that emerges from the internalized size stigma that we all have, because outside of extreme exceptions, you cannot simply look at someone and tell whether they are healthy, medically or psychologically. I have seen so many patients over the years who are approached when they're out walking in the street by somebody who says, "Oh my gosh, you look amazing. You must be so healthy. What's your secret?" And that patient is suicidally depressed and their gut doesn't function and they have no energy at all. But there's this mistake our eyes make that what you see reflects a certain health status. So let's apply an intersectionality lens, which is very, very important in the work. Let's talk about some folks who are missed and overseen and made invisible. The Gender and Body Image Study confirmed a high prevalence of chronic use of weight loss strategies, body dysmorphias, and a close connection between emotional distress and body perceptions in women over 50 years old. Indeed, the ED prevalence in women over 40 is estimated to be 3%, and in males, 1 to 2%. In my former hospital program, fully 25% of our patients at admission were over 40, and over 40% at admission were over 30 years old. So we have to erase the idea that this is only a problem of youth. Boys and men are finally starting to get more recognition. There was a good article in People last summer that got some attention. And I like showing this picture, partly because I'm a huge Star Wars fantasy sci-fi nerd, and so why not? And partly because it's so illustrative. The two action figures on the left are Luke and Han, as produced after the 1970s trilogy was released. The two action figures on the right supposedly represent the same characters and were released in the early 2000s when the lamentable next trilogy was released. What's key is to see how remarkably different their bodies are, despite the fact that the actors didn't change. And of course, the bodies on the right could only possibly be achieved, if indeed they could at all, by disordered eating and steroid use. So you say, okay, come on, Dr. G, they're toys. What's the problem here? Well, this is the typical costume that our little boys are asking for now. And when we put our little boys in costumes with pre-padded pecs, delts, and a six-pack, we are implicitly giving them the message that their own perfect little bodies can't be super or magical, that you have to be in this kind of a body in order to have the special powers. When we look at mortality rates in boys and men, they are shockingly high. A Swedish study looked at over 600 male patients who got hospital care for anorexia over about 30 years. The male patients with anorexia and any other psychiatric comorbidity, which we know is everyone, had a death rate 9 times higher than healthy peers. The ones who abused alcohol were more than 11 times likely to die of natural causes and more than 35 times likely to die of unnatural causes. A recent study from Japan showed that male patients had twice the death rate of female patients with anorexia nervosa. And broadly speaking, when we think about discrimination per se, the higher the discrimination experienced in an important study, especially along body size or skin color metrics, the greater the prevalence of binge eating. In fact, there was a 1,000% increase in binge eating compared with those who did not experience discrimination. With regards to trans and non-binary individuals, in a large study, those who were assigned female at birth and identify as gender non-binary had the highest rate of self-reported and formally diagnosed eating disorders. In fact, non-binary individuals were 3 times likely to have had an eating disorder compared with trans binary individuals. In another big study, transgender college students were 200 to 400% more likely to use eating disorder behaviors than a reference population of cisgender heterosexual females. And we always have to keep coming back. What is the eating disorder doing? What is the positive it seems to offer, even though in the long run that doesn't bear fruit? Here, for someone attempting to look like the stereotypical construct associated with their identified gender, eating disorders can make sense. Minority stress is incredibly important as well. It refers to the excess stress experienced by individuals in stigmatized social categories along the lines of gender, racial, religious, sexual, and others. It has a major impact on mental health because these individuals have pressures others don't have. So eating and body concerns affect everyone, and stigma harms everyone. Now let's talk about weight loss as a primary outcome, because we know this is what this country is obsessed with. Anyone who's been to a doctor knows that this is the obsession. Theoretically, the goal of the patient and provider is to improve health, vitality, and perhaps social acceptance. But the actual outcome of focusing on weight is weight cycling, dismay, and wasted time and energy. Because people start with a diet, either on their own or as prescribed by a medical provider. Biologically, their metabolism slows. The diet ends, they eat normally, they gain weight, plus some, because that is how we evolve. And they are stuck in this cycle where they blame themselves and feel blamed by others. Weight loss also drives a feeling of, or actual out of control eating. This is biology, not inadequate willpower. I love this little meme that says, to simplify, you must stop the restriction or it will never end. I like to say that when your ancestor and mine were walking through the rocky tundra and we hadn't really had enough to eat for a couple of days, and we got to the edge of a forest and we found a beehive, what they did not do was, oh, well, that was tasty, let's move on. Oh no, they knocked that thing down and they devoured all the honey, not because they have a sugar addiction, but because that's what kept them alive. And that is a biological drive. So weight and body composition focus is ultimately demotivating. There's the high of societally approved, exciting results that are celebrated by every human in your life that then leads to wanting more of that outcome high. And then a disappointing measurement may topple the house of cards, and it leads to an overfocus on the measurable results, whereas encouraging someone towards the process of taking care of themselves and not looking at numbers, that's self-sustaining. We have to acknowledge in this stupid numbers game that so many elements affect the numbers: trauma, stress, inadequate sleep, grief, loneliness, hormones, mood. But if the focus is on the process of taking care of oneself kindly, growth, values-oriented reasons really show why someone is taking care of themselves, and then it's more sustainable and joyful. But it is less of a high, and we have to acknowledge that. I love this quote from the brilliant Sonia Renee Taylor: "Body terrorism is a hideous tower whose primary support beam is the belief that there is a hierarchy of bodies. We uphold the system by internalizing this hierarchy and using it to situate our own value and worth in the world." Let's just go through a few examples of usually inadvertent harm caused by the current way medicine interacts with patients with a focus on weight. An adolescent boy is casually told by his pediatrician that he's getting a little chubby and needs to watch the sweets and eat a little healthier. This enhances the body shame he was already feeling from peers because he really respects the power of his doctor's words. And now his doctor is also focusing on his shape and size. So he tries to follow his doctor's recommendation, which leads to disordered eating and a meaningful risk for the development of an eating disorder. Better, how about psychoeducation about how bodies always change during the miracle and awkwardness of adolescence, to be patient and to keep focusing on unrestricted, balanced eating and enjoyable movement. A teacher who goes to her general practitioner for strep throat, or a twisted ankle, or a rash, or a concerning mole, and gets a lecture on losing weight every time. No one asks about her relationship with food. It's great. No one asks about her relationship with movement. It's great. Meanwhile, every colleague around her is talking about their new diet and body dissatisfactions all the time. If she has a history of an eating disorder, how can she stay recovery focused with these pressures? A newly retired woman is ready to work on her relationship with chronic dieting and body dissatisfaction, and she finds a therapist she really likes who feels values aligned. 2 months into therapy, she comes into a session and her therapist says, almost without knowing what she's doing, "Wow, you look great. Did you lose weight?" She terminates care. The primary care provider who functionally prescribes eating disorder behaviors to someone in a larger body by recommending dietary restraint, counting calories, regular weight checks, and measured portioning. The physician's assistant talks about their own diet and the weight loss app they're using, and they just don't realize the gross double standard being perpetrated compared with someone who has anorexia nervosa, when we know that these behaviors are known to be miserable, unsustainable, futile, and harmful. The surgeon who refuses to perform knee replacement surgery due to a high BMI, then lectures on how the person needs to get more exercise. With a knee that requires surgery, they may cite stats regarding worse outcomes due to anesthesia or healing postoperatively, but somehow the vastly more complicated and dangerous gastric bypass surgery can routinely be done on people with a high BMI. Then the withholding of a needed surgery actually becomes a tacit punishment for the perceived moral failure of fatness. Even more dangerously, the surgeon who refuses to perform gender-affirming surgery due to a high BMI. And I was so grateful to be allowed to participate in this brilliant paper that Lisa Brownstone authored with our other wonderful colleagues. The nurse practitioner who suggests increasing exercise for weight loss in someone who has atypical anorexia, who's been over-exercising for months to the point of injury, without asking first about the patient's actual relationship with movement. The RD who jumps to recommend a gluten, soy, dairy-free, low-inflammation diet for someone with digestive distress, without a super careful assessment for current or prior eating disorder behaviors, remembering that often diets like these can trigger disordered eating or an eating disorder, even in someone without a pre-existing problem. The coach who casually makes negative comments about athletes' bodies or compares one with another based on size, catalyzing pathology and creating a culture of body negativity, or thinks that athletes losing their periods is a sign of rigorous and appropriate exercise. The school that publicly weighs students who already understand from a young age that some bodies are deemed more acceptable and worthy than others. Or the school counselor who gives a talk on eating disorders that only includes pictures of emaciated white girls, not only triggering ED behaviors in some, but also silencing all of the ones who don't look like those pictures. The non-binary individual with atypical anorexia who gets both misgendered and dismissed by their general practitioner for eating concerns, since your weight's normal, so things can't be that bad. The gay college student who's praised by his doctor for being so fit, that is, looking a certain way, when in fact he's restricting, overexercising, and miserable. The trans woman who's told by her therapist to just love your body as part of her recovery work. The low-income man in a larger body who sees his cardiologist and gets the just drink less soda, eat more vegetables, and get more exercise lecture yet again, when in reality, there's not enough money for a variety of food. Even if there are no shops nearby that stock fresh food. He's working 2 jobs, both sedentary, with no time to cook at home. And there's no safe place to take walks in his neighborhood. And he has neither the money to buy nor access to exercise clothing that fits. And finally, this is so important, the parent whose child asks, "Am I fat?" And who responds, "No, honey, you're beautiful." Look what we did there in responding too quickly. So let's look at health outcomes. Because when I talk to healthcare providers about this, the first challenge I get is, okay, Dr. G, weight stigma sounds pretty bad. But what about health? We're all about health in this country. We want to be healthy. Isn't weight loss and being thinner healthier for your body? Let's talk a second about healthism. Another brilliant quote from Sonia Renee Taylor. Equally damaging is our insistence that all bodies should be healthy. Health is not a state we owe the world. We are not less valuable, worthy, or lovable because we're not healthy. Lastly, there's no standard of health that is achievable for all bodies. Our belief that there should be anchors the systemic oppression of ableism and reinforces the notion that people with illnesses and disabilities have defective bodies rather than different bodies. Healthism, addressing healthism, asks us to consider that we must not mandate explicitly or implicitly that everyone should want the same health outcomes. And my citing health statistics in the coming slides in no way implies that everyone must want to live the longest possible or with any specific level of function, or must want to or be able to change their behavior to do so, or has the resources to do so. Trigger warning, I am going to talk about the benefits of exercise, contrasted with a focus on body size and diet. To be clear, everyone's eating disorders, ears perk up here, please. This means appropriate exercise, properly fueled and properly rested. I'm also going to use the language cited in articles, which includes the O words that I never use and think are harmful. This is a terrific review article to help combat medical provider beliefs that we should be focusing on weight as a primary outcome. The author writes, the increased prevalence of weight loss attempts in the United States has coincided with the increased prevalence of obesity. Thus, a weight-centric approach to obesity treatment and prevention has been largely ineffective. It is unlikely that continued focus on weight loss as the primary metric for success will reverse the trends in obesity prevalence or result in sustainable weight loss. In fact, chronic weight cycling is the norm for millions of adults and is likely to remain so for as long as weight loss persists as the cornerstone of obesity treatment. P.S. Fatness does not need to be treated. It is not a medical disease. Weight cycling is associated with health risks that are very similar to those associated with obesity, including higher all-cause mortality risk, and may contribute to weight gain. He also says, the desire to lose weight is often incompatible with physiology. So let's look at this. About 50% of US adults have tried to lose weight within the past year. I bet that number's higher. There's something called the weight loss futile cycle, where studies show a high prevalence of weight loss attempts during which weight has risen. Weight stigma has clearly been associated with numerous adverse health outcomes and increases all-cause mortality. People say, okay, let's talk about BMI and mortality. First of all, BMI is baloney. It should be tossed. But it's what doctors are using, so we have to refute it. Not all studies show that this so-called normal BMI of 18.5 to 25 kilograms per meter squared is the range associated with the lowest mortality risk. In older adults, in fact, the lowest mortality in never smokers is 23 to 33 kilograms per meter squared. never smokers without pre-existing conditions have increased risk at both the lower and higher ends of the BMI distribution. And of course, BMI doesn't account for differences in body composition, fat distribution, ethnicity, meds, trauma, the whole 9 yards. Also, analyses of BMI and mortality almost never consider cardiorespiratory fitness, which I will show you has a high impact on mortality risk. So what is this cardiorespiratory fitness? Well, it means that the more you're able to do really good hard work with your body while resting it and hydrating it and fueling it, the mortality risk associated with BMI is either eliminated or greatly attenuated. In fact, low fitness is associated with a 2 to 2.5 higher risk of all-cause mortality, regardless of BMI. Low fitness, in fact, is found to be more hazardous than high BMI. An example, in the UK Biobank cohort, men and women who just self-characterized their usual walking pace as brisk had a much lower 7-year all-cause mortality risk and a higher estimated 10-year survival compared with those who said they walked slowly, entirely independent of BMI, which ranged from 20 to 44 kilograms per meter squared, with a really nice range as well of body fat percentage. Strength matters. We know muscular fitness improves the risk of chronic disease and mortality independent of BMI. This UK Biobank study showed that hand grip strength quintiles among men and women neutralized all-cause and cardiovascular disease mortality risks when comparing the highest and lowest percent body fat. When stratified by BMI, the all-cause mortality for the strongest folks was not different across all BMI categories, and for women, it was the same through a BMI of 35. Okay, what about intentional weight loss and mortality? Because what doctors are prescribing is intentional weight loss through caloric restriction. Big prospective cohort study, meta-analysis, looking at patient type and intentional weight loss. Those who were considered unhealthy, I don't know exactly how they categorize these, when they intentionally lost weight, did have a somewhat lower all-cause mortality. Those who were healthy had an 11% higher mortality. Those who were mostly healthy without obesity, higher mortality. Healthy with obesity, unchanged mortality. So on the whole, we're looking at a higher death risk or identical with intentional weight loss without even taking into account all the downsides and negatives of intentional weight loss. The Look Ahead trial was stopped for futility because the results failed to show a difference in the rate of death, non-fatal heart attack or stroke, or hospitalization for chest pain among patients with type 2 diabetes randomized to intensive lifestyle intervention versus control, even though the intervention group lost significantly more weight. There was no difference in the outcomes. And intentional weight loss is really quite futile. A meta-analysis showed that weight loss in studies averaged about 8 pounds from control groups after a year in very highly controlled and supported environments, which decreased to about 5 pounds differential after 3 years. So these eat less strategies and the primary focus on weight loss both cause harm and aren't effective or sustainable. And PS, in the studies that showed a benefit of weight loss, it was unclear whether it was the weight itself or the exercise piece, because many of these studies included both diet and exercise. So question, is it about losing fat? A liposuction study was done where there was no benefit in cardiovascular disease risk profile or insulin sensitivity when the amount of fat removed, 1 liter to 16 liters, is compatible to or greater than the weight loss seen with lifestyle interventions. In fact, after people have liposuction, they universally develop compensatory increases in visceral abdominal fat, which are actually worse for health outcomes. and can be mitigated by aerobic exercise. So it's not about the fat. Bariatric surgery, it is true that some studies show that this reduces the risk of all-cause mortality, micro and macrovascular disease, and remission rates for type 2 diabetes. And that suggests it's the weight loss that drives these. But blood glucose levels and insulin concentrations rapidly improve within days of surgery before any weight loss. Physical activity may improve after bariatric surgery, which, by the way, accepting that everyone must make their own choice is not something that I'm a fan of. So the physical activity might be the driver of the better outcomes rather than the weight loss per se. And in a study of 4,400 adults with type 2 diabetes who underwent the surgery, the weight loss was identical in those who continued not to have diabetes versus those who redeveloped it. Okay, let's think about physical activity. Fueled, rested, and hydrated. Increasing physical activity is associated with a 15 to 50% reduction in all-cause mortality and a similar reduction in cardiovascular mortality and events. In the Oslo ischemia study, reminding us that physical activity isn't for weight loss, and it doesn't cause weight loss for the most part. Physical activity is about being stronger and more vital. In this study, among men who were not fit at baseline, the change in their BMI was not different when comparing men who remained unfit versus those who really got fit. So there were ones who stayed less fit and ones who got really fit, but their BMIs were the same. And yet, those who got fit at follow-up had a third lower all-cause mortality and a 60% lower risk of stroke. In a study of Danish adults who just took up cycling, there was a 22% lower risk of all-cause mortality during the quite long follow-up, and there was no reduction in body weight among those with high weight at baseline. There was no reduction of the incidence of overweight or obesity. Cycling did somewhat reduce abdominal obesity, where this does pose a greater health risk and reflects a tiny percentage of total body fat. Now get ready for this one. Weight cycling. This is going to knock your socks off, and it may be a little tough for some to hear. Weight cycling means gaining and losing weight over and over. In the largest meta-analysis of weight cycling and health risk, there was a 41% higher risk of all-cause mortality, a 35% higher risk of cardiovascular mortality, no effect on cancer, and a 35% higher risk of hypertension, just from the weight going up and down. Even more astounding, when you compared in this one study the patients who had the least body weight variability with those who had the greatest body weight variability, those with the greatest had an 82% higher risk of a major coronary event or death, a 99% higher risk of heart attack, a 92% greater risk of stroke. And the greatest risks were observed in those with overweight and obesity. That is, the ones that doctors are most likely to prescribe diets for, and therefore, biologically, weight cycle. This raises the question, are some of the risks of morbidity and mortality seen in some studies in those with high BMI actually unrelated to the high weight at all and actually attributable to weight cycling? Weight cycling is also associated with the development of something called sarcopenic obesity, and not words that I use, as weight regain after loss is characterized by greater gain of fat mass than fat-free mass. And weight cycling was associated with lower strength. So let's just think about physical activity itself. It was associated, compared with weight loss, with equal improvements in risk markers like blood pressure, glycemic control, blood glucose, which occurred whether they were doing aerobic or resistance strength training, in lipids, in vascular function. Independent of BMI, just getting more active as long as you're caring for yourself through it majorly improves your health. It also, if we're getting into it, reduces higher risk fat. Visceral and ectopic fat is associated with an increased risk of certain diseases, and exercise reduces both of these even though it doesn't reduce or change weight because it reflects such a tiny fraction of our weight. All right, so some people who are really, really fat stigmatizing say, yeah, well, fat people cost more. Nope. The Veterans Exercise Testing Study showed that the annual costs for a moderately to highly fit man with obesity were $10,000 to $27,000 lower than the health costs for the least fit men in the normal BMI category. When we think about the sustainability in the Finnish diabetes prevention study, twice as many participants were able to achieve the physical activity recommendation as were able to achieve the weight loss goal. And in almost 16 years following up adults with coronary artery disease, compared with those who remain sedentary, sustained low physical activity reduced mortality 20%. Sustained high physical activity improved mortality 36%, while weight loss was associated with a 30% increased mortality risk. Weight gain was not associated with mortality. So it is clear that any stakeholder in improving health and mortality the way the medical system says it cares will stop focusing on weight as an outcome and will support general good care and, for those who want it, improved physical activity. So bigger questions are, how can we make this more accessible for everyone? Appropriate clothing and shoes, safe, affordable spaces, outdoor access. The focus on weight loss for health must be understood as scientifically inadvisable and sizist. The good news is that weight inclusivity applies to everyone. There are so many wonderful books out there. These are among my favorite, not to mention all of the great podcasts. Health at Every Size, Haze, advocates for accepting and respecting the natural diversity of body sizes and shapes. Eating in a flexible manner that values pleasure and honors internal hunger cues, moving for joy and to become more physically vital according to ability and desire, and advocating for respectful healthcare and policies that acknowledge the importance of social justice themes. It does not, as the trolls just love to try and claim, mean that everyone in every body size is healthy. I recommend you all Google this if you haven't seen it. Google Poodle Science ASDA, the Association for Size, Diversity, and Health. It is charming and delightful and so immediately understandable by people. What does eating for joy mean? Well, food is not morality. All foods are fair game. The goal is abundant, unrestricted, satisfying food throughout the day with general balance and moderation. Moving for joy, what's the patient guide? Well, first, the patient states their goals and values. Then they decide with their provider if movement would assist in achieving these. They receive support on making sure that movement can happen safely. They give it a go and keep assessing. For those in larger bodies, and I don't have any financial relationship with them, the Join app is really nice. It's got really good representation. So then what in the world is weight inclusive medical care? Because the medical system does not seem conducive to this. Well, it's holding awareness that higher weight can contribute to the development of certain medical problems, as can trauma, stress, poverty, and all modes of otherization. And still never recommending weight loss or change of body as a treatment. It means that except when monitoring nutritional rehabilitation, we don't check or discuss a patient's weight, except in so much as to provide a safe space for them to have feelings about it. It's not perpetrating diet culture on patients or allying medical recommendations with society's weight biases. And that ultimately, if a patient does develop any of the medical issues associated with higher weight and all of the other things, I treat them because that is literally what I'm trained to do as an internal medicine doctor. And it's tempting, especially for thin-bodied providers, to suggest a little weight loss because we are brainwashed by societal promotion of thin privilege, but that will only lead to weight cycling. Super important, super important. All fat bodies are worthy, not just the healthy ones. So probably if I could go back in time and change the name, I would say worthy at every size. Important to just pause for a moment because not all contributions come with a literature citation. These are among my most beloved and gratitude-inspiring teachers: Carmen Kuhl, Erin Flores, Hilary Canavy, Deb Burgard, and Desiree Attaway. Okay, let's do a couple of cases. Ben is a 26-year-old swimmer who just started graduate school and has gained some weight as his schedule has changed. He comes in to see PT for shoulder pain and asks about whether he should try the keto diet to take off the weight. Sarah is a 30-year-old triathlete who lost her period 5 months ago while training. She's been going from event to event without a rest period and has rehabbed 2 stress fractures. She wants body composition measurement. Patricia is a 61-year-old runner who's frustrated that she's carried extra weight, especially around her middle, since menopause. At her annual physical, she identifies that she's been eating very healthfully with strict food rules, but her daily weigh-ins don't seem to be changing. She wonders if she needs B12 shots for fatigue. So keto diets, they're evidence-based really only for childhood epilepsy. They're currently very highly touted for type 2 diabetes. And in some patients, I've had to get humble about this, they can be helpful for digestive issues that don't respond to anything else. But fundamentally, they are a favorite new diet in health clothing. The actual impact of a lower than 50 gram carb, 75% fat diet on athletes is super uncertain. And we know that diets that contain less than 100 grams of carb a day reduce gut microbiome health, which is vital for our overall wellness. And mainly, the restriction can too easily trigger that scarcity mindset, which is biologically imbued in us, and lead to weight cycling, binge eating, and abnormal relationship with carbs. So for Ben, just encourage him to take care of himself and stay well-rounded as he starts his master's program. We're going to educate him about the pitfalls of restrictive diets and the likelihood that his body weight will regulate with time and balanced living. Whatever direction that goes, it's going to be fun. But we do want to inquire about his degree of body distress. He might need more support. The relative energy deficiency in sport, or REDS, has replaced the female athlete triad. We don't use that anymore because it's more encompassing of all the issues related to bodies, food, and sport. And what we see in this great diagram is that, as we know from any kind of restriction medicine, every possible body system can be influenced by inadequate fueling relative to what one is doing with one's body. So for Sarah, let's ask some open-ended questions about her decisions to train and compete constantly, about her relationship with those measurables, times, distances, body comp, and about her fueling. Let's discuss REDS versus an eating disorder and how her 5 months of amenorrhea reflect undernourishment and may be influencing her bone density. We should consider a bone density scan. Let's offer referral to, I left a little piece in there, to a great RD and an exercise physiologist to learn how to care for herself. And help her consider this, that someone acting from athletic identity will do anything to improve their performance, including rest, eat more, let their weight come up. While someone who is acting from a more disordered eating or eating disorder identity is driven by fear and will not be able to reduce training, increase food, or rest. With regards to menopause, it's normal to expect weight gain after menopause, even as we know very clearly that thin privilege is often seen as ameliorating the negatives of aging. However, we know that women who gain after menopause live longer, and the extra fat becomes the primary source of estrogen production, which is great for bone health and for orgasms. Undereating is going to keep metabolism low, causing fatigue, poor sleep, worse digestion, worse muscle strength, and makes one more likely to gain weight in the long run if that's something they want to avoid. This probably isn't a B12 issue unless she's an unsupplemented vegan. Let's normalize and celebrate the body at this stage while validating the pressures on women at all stages of life, and that no woman in particular is allowed to be enough, regardless of how they look. Let's laud her ongoing running as long as it remains joyful, and encourage she supplement it with strength training, increase her intake, and throw away the scale and buy clothing she feels great in. Let's do 4 little cases of people at risk for cardiometabolic disease. Liliana is a 38-year-old who has an extensive family history of type 2 diabetes. She feels great, exercises, has a good relationship with food, and is comfortable in her body. She wonders what she should do to reduce her risk of future medical issues. Gabrielle is a 29-year-old who's been encouraged by medical providers to lose weight since she hit puberty. She's tired of the dieting cycle, which never works for long, even though she wants to lose weight. She dreads coming to the doctor, given the lecture she always gets. She hasn't had a physical in 5 years and has never had a PAP. Mita is a 33-year-old whose father had his first MI at age 53 and whose uncle died of a stroke at age 49. She never did sports growing up and worries about having inherited the family atherosclerosis. Andre is a 27-year-old with a bad back from years of high school and college sports. He sees his chiropractor regularly, which really helps. His mother developed kidney failure from long-standing type 2 diabetes and hypertension, and ending up on dialysis is his biggest fear. He has well-treated hypertension, and he usually tries 2 to 3 diets a year because he hears they're the way to stay healthy. All of these 4 deserve one standard of medical care. Resist the temptation to make assumptions about someone's health, activity level, or relationship with food just by looking at them. Ask. Name that you don't feel any need to check their weight, because this really isn't a vital sign that's meaningful for any of these patients. Really, it's only for medication dosing, monitoring growth in children, and weight restoration in those who need it. Knowing how much body fat is visceral versus not is not going to change our management, but it may lead people to feel hyper-focused on numbers. Encourage satisfying, generally balanced, consistent food, and refer to a dietitian as needed. Discuss the dangers of weight cycling. Focus on the benefits of physical activity and slowly building cardiorespiratory fitness, including strength work. Check an A1C annually, or if someone has symptoms, only after asking consent. This is a loaded lab value for many that can carry a lot of weight stigma. Connect with all the other health team members about your weight-inclusive perspective so the patient is protected from bad care. Validation and education helps patients start to accept Haze. This is my book. This is sick enough. It is available. I always end my talks on this slide, the title of which is Know When Your Ass is Overwhelmed. Take care of yourselves. You are living in an unbelievably challenging time. And while I bet almost everyone listening to this is incredibly good at taking care of other people and seeing what their needs are, probably we can all work a little bit more on understanding and honoring our own needs. That's it, and I am delighted to answer questions.
Thank you so much, Dr. Gaudiani. Yes, we have some excellent questions already, and I want to encourage everyone to use the chat feature if you would like. I'll still have time, I think, to take a few more. So this evening's audience is really vast with a lot of different experiences. I'm going to try to take some questions that are from professionals, also from individuals and family members. You touched a lot throughout your slides on research and showing the prevalence amongst marginalized communities and how challenging it is to be in recovery while seeking help in a system that is sort of stuck in BMI and weight stigma. So I'm going to start with the first question, which is how or what kind of encouragement rather may you have for someone who is trying to figure out when to reach out for more help, or how to decide what is an appropriate level of care for them?
I love that question. Well, by the very nature of the title of my book, I respect that not feeling sick enough for help, for a higher level of care, to change behaviors is endemic in the nature of eating disorders. And it's further worsened by a medical system that often minimizes patients' symptoms, doesn't know how to look for what goes wrong with eating disorders, and leads patients, again, to feel that they're not sick enough. What I can tell you is, if you have any question about whether you're able to do the work that gets you towards your own unique goals and allows you to honor your own unique values, then ask for more help. There's not a specific weight, there's not a specific lab number, there's not a specific heart rate that determines your need for more help. If you're not able to do what matters to you, work through recovery at a certain level of care, try to get more help.
I'm going to add a reminder onto that, even for all the information that was just shared with us, for everybody to even revisit the recording and pause and take some time to process. How does it relate to maybe your own journey in recovery or your loved one who's also in this journey? And reach out to the Eating Disorder Foundation. It is exactly what we're here for, to kind of talk about all of us with our individual experiences and access to these, different levels of care, or really just connection with those who understand. I'm going to now ask kind of the flip side almost, for those who are working with clients and are still utilizing the information that you may as a nutritionist or a medical provider, so working from labs. So the question is, how do you recommend working with blood work numbers and lab results from a Haze perspective while utilizing that information?
Yeah, I think what I love about Haze is that it applies to everybody. There's not a double standard of this treatment for this group and this treatment for the other group. So the answer is the same across the entire body size spectrum, which is, if I'm checking labs and it's in someone with an active eating disorder, regardless of body shape or size, I try to anticipate in advance and say, these labs may be completely normal. That does not undermine the seriousness of your eating disorder or the appropriateness and urgency to move forward in recovery. Labs aren't everything. They're one little piece of the pie, and I need to see if there's anything I can do about them, like a low potassium, for instance, or following how organ function is going. But they do not define your worthiness for care. And if I get labs back and, let's say that somebody has developed diabetes, and that may be in part related to their higher body weight, we have a really thoughtful conversation about that. And I say, I'm still not going to check your weight. I'm still not going to recommend weight loss. There's plenty of things I have to treat diabetes. And let's continue to focus on you as a whole human, because you are worthy and wonderful, regardless of your numbers. And we're not going to put you back into the weight cycling hopper or back into the nightmare of your eating disorder, risking relapse, just because Western medicine likes to focus on weight in these circumstances.
I'm going to ask, and I feel like the questions are only going to get more challenging, but it's so true, because everything that you're saying is a challenge to how all of us have grown up in the world and the ideas that we have. So let's just talk a little bit about it, because I think the idea too of health at every size is a really challenging concept. So it sometimes on one side almost sounds like, okay, so our question here is, so I can, regardless of weight, totally ignore and do what I need to do in life. That, like, how do I figure out what is healing and what is the right thing to do in my recovery then? If I'm totally just putting the whole number and idea of weight in a box in a corner and not going to look at it.
I love it. Where you have resources for a wonderful therapist and dietitian, they can be so illuminating to help you answer that question. Because the ultimate goal is to give yourself good, satisfying food throughout the day and not be overvaluing your worth based on what your body looks like or how your clothing fits. And to decide what satisfies you, what fills you, what brings you joy and recharge. That actually becomes the goal, because when people do those things and they get whatever level of movement is congruent with all of the variables we've talked about, that is as healthy as food and movement can make you, whatever body size that brings about. That's the answer. And so the quest then becomes not, how do I satisfy the world around me? How do I try to fit into this incredibly narrowly defined band of what is supposed to be optimally privileged? But rather, what do I myself need and how can I honor that?
Can you offer some words of advice to families who are encouraging their loved ones? That might be high school age. It could be spouses, really any age right now. I'm getting a lot of questions about the focus you had on the positivity and the joy that movement has in life and exercise. And the difficult part in recovery, where even medical providers or therapists, those who specialize in eating disorders, are saying, okay, we need to put a pause on this, or we need to stop for a certain amount of time, kind of saying like, all right, I'm getting this confused message. If it is such a benefit to one's well-rounded life, how do I include this? Because I'm being told to really put a pause. And so how can an individual really take that information, and also even like family members and caregivers around, really help encourage that kind of confusing message?
Yeah, beautiful question. Thank you so much for letting me clarify. There's a couple things on this. First of all, there are certain people who don't currently have safe bodies to do movement. In the same way that someone who just broke their leg in a skiing accident by no means should be encouraged to get back on their skis and get out there. That's just inappropriate. There are people who, either because of their present medical condition, their present ability to fuel, hydrate, and rest, or their recently ongoing excessive relationship with exercise, where it stopped being joyful and it became grinding, requirement, disastrous if they didn't do it. Those folks are not safe to exercise right now, period. And it is not healthy for them. But I also think that the eating disorder field has gone way too far in preventing people from engaging in moving their bodies once they have the fundamental stability across those three markers to do so. I think that when doctors say you can't do your sport for a year, they're reinforcing people's idea that movement is just for burning calories and you don't want me to burn calories, so I can't move. As with the data I showed, movement isn't for burning calories, but someone must have appropriate fundamental medical stability, the ability consistently to nourish themselves appropriately for baseline care, for weight gain when necessary, and for the movement they're doing to fuel their muscles. And they have to have a relationship with it where they can be flexible. They can take rest days. They can spontaneously realize they're not going to be able to work out that day and keep their brain inside their skull. I love bringing patients back into their sports, because the more we can inculcate the athletic identity to replace the eating disorder identity, the better. It's so much more fun and cool and delightful and relational to be a teammate than to be someone with an eating disorder. So, my sense is when people are stable enough medically, and that's going to differ per the person, but it involves heart rate and, a variety of other features. When they're nourishing consistently, and that involves not purging, because exercising while you have a super low potassium can absolutely be deadly. And then being able to manage a widely varying set of exercises. I think it's great when people can do that.
I'm still getting amazing questions, and I'm still reading through them. I'm going to shift gears into some experience as a medical professional to those. I suppose it's more of an advocacy question in the moment. You, Dr. Gaudiani, have this understanding and compassion and so much experience with working with people who are struggling inside their bodies for a number of different reasons and causes. So when I'm kind of two-part question, have you experienced people coming to you and saying, here's all of the information that these previous doctors have told me. They've told me to eliminate a certain amount of things from my diet for medical beneficial causes. How do we, so the question is really how, as a client coming in and getting sometimes misinformation that perhaps isn't intended to harm, but is directly harming the eating disorder, and kind of validating those thoughts. How can someone who's in recovery speak up in that moment, which I know is often, right, having a support person, having someone with you to encourage you, standing that yourself as well. What might you say to someone who has been given and told that they're wrong or that they should be eliminating something from their diet, and they know, like, that's not a piece of my recovery? How can somebody advocate in the moment to a professional?
I mean, I want to validate that it's really hard. It's really hard. Medical providers have a lot of power. They have the power over your prescriptions, maybe the power over your family members' healthcare as well. Speaking up and challenging the healthcare system, at best, can be a wonderfully knowledge-inducing and validating experience with your provider. I'm so grateful when my patients tell me I've messed something up or that I've hurt them, because it gives me an opportunity to repair with them, to listen to their perspective, to learn and to do better myself. And I still make mistakes all the time. However, if someone feels strong enough to try to resist, to try to speak up, as you said, Sabrina, having somebody with you who can step in if you end up in a frozen trauma moment because the doctor says something that's traumatic, or just gives you that feeling of helplessness and an inability to speak your truth. The best thing you can probably do, appreciating that our healthcare system is so complicated and inadequate, is to find a provider who's curious and kind. If you find a provider who's curious and kind, they'll want to learn about Haze. They'll want to learn about you. And that's going to be the opening for the dialogue that the two of you will have. Trying to stay in recovery communities, both live, where that exists still, and virtual, can be very helpful, because there is trauma inherent to eating disorders themselves and to eating disorder treatment, because both are existentially threatening and feel out of your control. So the trauma experience of freezing in the office, or of not speaking your truth, or of not saying something back to a provider who's harmed you, can end up leading you into a shame spiral later on of, like, why didn't I use my voice? I once again was victimized here. And being part of communities can really help validate you. They can give you words to feel strong, to say, I'm not going to get weighed in the office today. You can write on the form declined, and that will satisfy the insurance requirement. You know, please change me to a different provider. You have the right to do that. And what we try to do with the patients we see in our office is to begin a reparative experience so that everything is rethought, from consent in the physical exam and in the discussion of certain topics to the complete and utter commitment of everybody in our office to Haze and to weight neutrality. And to fat positivity, not just to weight neutrality, but to fat positivity.
We are out of time, and I want to thank you, Dr. Gaudiani, for giving us your time and your experience. I want to remind everyone that this recording will be sent out to everybody who registered in the next couple days, so as soon as possible. I apologize we didn't get to everyone's question, but I'm going to save a few of them and hopefully just encourage everybody to continue reaching out. I feel like that's one of the main themes from all this information. Dr. Gaudiani, thank you so much.
Thank you so much for having me, and thank you everyone for joining.